Good evening. The next hour or so, we're going to talk about something that's occupied me for most of my academic life. My name's Tim Coates. I'm Professor of Emergency Medicine in Leicester in the UK. And we're going to be talking this evening about the coagulopathy of trauma, something about blood clotting after trauma, what we might practically do to reduce blood loss, and the impact of anticoagulant drugs. I'm going to talk there particularly around, there's been quite a bit on Twitter over the last couple of weeks around the NICE head injury guideline that came out last year, and what does consider transporting the patient for a CT actually mean. So we'll get into some of these topics. So I'm not a hematologist, so I'm not going to be putting up lots of diagrams with different compounds and lots of different chains. We're going to go back to some of the basics. Some of this is also, I think, my history, my story in medicine and in academic medicine, because I became interested in coagulopathy of trauma in the late 1990s. So I guess looking back, that's getting on for 30 years worth of interest in this area. So coagulopathy of trauma. I want to take you through a little bit of a story about the discovery of this, and it really came about by serendipity. And that wasn't a word that I was sort of that familiar with at the time, but it's how you find something interesting by chance. And really, the discovery of the coagulopathy of trauma came across by chance, and it all started with a mistake that was made by one of our nurses at the Royal London Hospital in the early 1990s, when we were just setting up the trauma system there, and I was one of the consultants that set up the London HEMS helicopter. We were just starting that. We were setting up a new resuscitation room, thinking of this strange thing called a trauma team that we'd get together, which is now very familiar, but in those days was a bit radical. And to make the team more efficient, our lead resus nurse decided that instead of collecting blood bottles from all the different containers for each patient, we'd have a pack in a plastic bag, and the junior doctor assigned to taking bloods would just fill the bottles that were already ready for them in the plastic bag. And she wasn't, I think, quite sure which bottles to put in. So she decided to put in one of each, and if you put in one of each, then that can't be, you're going to get what you want. And that meant that she put a coagulation tube into the set. Now, at the time, a coagulation screen wasn't something we did in the emergency department in trauma patients at all. We knew that blood clotting was abnormal after trauma, but thought that was something that happened in ITU sort of hours after the injury, and was caused by, us doing things to the patient, like giving them fluids, operating on them, and then by the time they got to ITU, they got the coagulation tested, and it was abnormal. So it was something that was, there was an article written at the time called The Ultra Early Changes in Coagulation After Trauma, and the first measurement there was 24 hours after injury. So measuring something, no one would have thought of measuring coagulation in the emergency department because it wasn't a problem there. But we had all of these tubes put together, and then after about 5 years later, so we're looking at the late 1990s, there was a medical student called Jasmine Singh, and Jasmine came to me and said, look, I'm going to be in London through the summer holidays. I'm going to be really bored at home. Have you got a research project or something that I can that I can do? So, it's when you're an academic or a teacher, having students coming and saying, oh, I'm really keen, I'd like to do a research project with you, you get this sort of positive feeling, great, somebody's enthusiastic, but you also get that, oh, I've got to find something for them to do, what can they do? So I said to Jasmine, why don't you get all of the results of all of the trauma patients that we've been seeing over the last 5 or 6 years from the helicopter system and just look at those initial blood results. I was sort of more interested in wondering what the white count was and how quickly the inflammatory processes started after injury. And there was a guy called Karim Brohi, who some of you may know, who's one of the registrars in the system, and he was working with Jasmine and looking at this data. And they came to me and they said, there's something screwy about this data. The clotting is abnormal. We've got clotting data because we've got it, and a lot of it's abnormal. And this was just, again, really interesting. We didn't know we were looking at anything really significant. So one of the things that you do in trauma is say, okay, I wonder how it changes with injury severity. And then we saw this graph, and this really made us sit up and take notice, this sort of linear relationship with injury severity. And I thought, well, trying to work out what is going on here, why does it look like that? And then we said, well, let's also look with mortality. And if you look at, in each injury severity band, the black line are the coagulopathic patients, and the patients with a coagulopathy on arrival in the emergency department have a very much higher mortality than the white columns, which are the patients who don't have the coagulopathy on arrival in the emergency department. And this was really weird because it meant that this was a pre-hospital phenomenon. These patients were developing the coagulopathy in the pre-hospital phase. It wasn't what we were doing to them in the hospital, the vast dose of fluids, the surgery, the cooling from all the exposure, as was conventionally thought at that time. There was some sort of process going on that seemed to be more intrinsic to the injury itself to give this abnormal blood clotting, and it seemed to be important because it was related to death. So we ended up writing a paper on this, which is what you do in an academic life, published in the Journal of Trauma there. It took a long while to write the paper and quite a lot of revision. I don't know if you can see down in the bottom left-hand corner of the paper, we submitted it for publication on February the 24th, 2001, and it was accepted on March the 11th, 2003. So even in the publication process, that was more than 2 years of backwards and forwards with reviewers and editors who were, like us, were a little bit puzzled about what was going on here. But I think this paper was really the start of this whole area, which then over the next few years has exploded with lots of people being very interested in this. And a number of different names being given by different groups. So you might hear ACOT, TIC, or ATC, and these are all the same things. I don't think these are talking about different conditions. They're talking about these changes that happen to the coagulation system that seem to be intrinsic to the injury itself. So whatever you call it, whatever you see people calling it, it's the same thing that we're talking about. And this is, I just did a quick search earlier this year on trauma coagulopathy. We published our paper in 2003, and there was a bit of interest in trauma and coagulopathy before that. That was, talking about these late occurrences in ITU, what combination of different factors you should give the patient in the intensive care unit once they get the coagulopathy later down the line. And then there was this explosion in research papers on trauma coagulopathy, which then all focused on this very early phase, which is really the pre-hospital and the early in-hospital phases, which seem to be, where everything is going on. Even look at that. Last year, 1,224 academic papers published with trauma coagulopathy as a topic. It's obviously something that really interests people around the world. So that's a bit about my story of the discovery of this condition, I thought it's worth just having a few concepts of what's happening in the body and what's happening in the body to enable blood clotting after trauma. And what's going on is a series of checks and balances. There's a sort of, a yin and a yang on each of the processes that's going on, with things that are stimulating the process and things that are dampening down and putting the brakes on the process. So everything about the coagulation system is a series of balances between these different factors. And that's what allows our blood just to continue circulating. It's important that blood clots when you have an injury, but it's important that blood stops clotting. So, if you had a paper cut and the blood just continued clotting and it propagated throughout your whole blood system, the whole of your circulation would seize up and you'd die from a paper cut. So there's got to be balances that make clotting start to heal up the paper cut so you don't bleed to death from a paper cut, but also stop the clotting so that you don't solidify your whole coagulation system. So that's just one extreme example of how there are a series of balances going on. And there are two main sort of processes that are happening. One is a series of processes to make clot, that's hemostatic thrombosis. But once you've made clot, you can't just keep clot in your circulation. You've got to break it down. So there's a series of process on clot breakdown, which is fibrinolysis. And what's happening after injury is this balance between clot making thrombosis and clot breaking down fibrinolysis. Now, each of those two processes, making clot and breaking clot down, have a series of biochemical pathways that either accelerate or break that process. And you'll see maybe some really complex diagrams of lots and lots of different compounds that are all involved in different ways and interact in different ways. And what that is really a very complex system to create a balance between those, the clot making, the clot breaking, the pro-clotting, the anti-clotting processes, the pro-fibrinolytic and the anti-fibrinolytic processes. And it's this wonderful sort of balance which allows us to have a liquid blood circulation, but then the blood solidifies in order to stop bleeding when we get an injury. And that's a pretty marvelous thing, really, isn't it? So no wonder it's quite complicated and no wonder we don't really understand it. But I think this overall picture of pro-clotting, anti-clotting, pro-fibrinolytic, anti-fibrinolytic, giving you a balance between two processes, which is clot making and clot breaking down. So that's the sort of concept that underpins what we're then trying to do when we're treating the patient. So if we go on to how to reduce blood loss, there's a number of different ways of doing this. There is a great guideline, the European guideline here. I was involved in the first few editions. The latest edition came out last year. There's a QR code there to link through to it. If you're interested in the bigger picture of the management of coagulation from pre-hospital through the emergency department, surgical and critical care phases, this group is really is the definitive word on how each of those phases is managed. So yeah, if you want to know more in depth, this is really one of the places that you should just go and read. I'll just leave that for a minute in case you want to grab the QR code. So the ways that I want to talk about reducing blood loss are physical, environmental, temperature, talking about drugs, and then surgery. If we take each of those in turn, I think the physical is sometimes perhaps neglected a bit in research. People are really keen on researching the latest fancy drug that might affect bleeding, but how different methods of, say, splintage work, to what's the best method of splintage to reduce bleeding. That sort of thing isn't the sort of sexy academic thing that people are looking at. But I think these are really important and stuff that we can do that is really good patient handling and patient care. Minimizing movement. We used to do log rolls on everybody, and you'd see people's blood pressure plummet after you'd done a log roll and crunch their bits of pelvis around by moving them on the... We used to say on ATLS, if you've only examined the front of the patient, you've only examined half the patient. You must do a log roll. And I think that was so wrong for us to be saying that. You look back and you think, God, some of the things we taught, even 20 years ago isn't that long ago, that were probably harming patients. So now minimizing movement, not doing log rolls, using a scoop stretcher to move the patient wherever possible, and it's good splintage, particularly of long bones. The pelvic binders, although there's not absolute evidence around them, seem to be good. We often, I find, particularly first aiders, often forget elevation and pressure. Certainly the general public doesn't know elevation and pressure. The number of people that come into the emergency department dripping blood everywhere, and the triage nurse stops the bleeding simply by sticking a hand right up in the air. And the amount of blood you lose is a function of how fast you're bleeding and how long you're bleeding for. So you can do all the things to minimize how fast you're bleeding, but you also need to minimize how long you're bleeding for. So that is getting the patient rapidly to definitive care, not spending time on scene that you don't need to, not spending time in the emergency department that you don't need to for patients that need surgical correction of their bleeding. Probably when I was talking about elevation and pressure, I was going to mention head wounds in particular. I think we're quite bad about putting on pressure on head wounds sometimes. Quite a lot of patients that go through the trauma system with a large wodge of absorbent dressing stuck on a head wound, pooling a large amount of blood. And most head wounds are very amenable to being controlled with a small dressing and pressure on the points that are bleeding. There is no need to worry about causing more brain injury by putting pressure on the outside of the head. So elevation pressure, minimizing time to surgery. This is all the sort of stuff we regard as basic, but sometimes I don't think we're that good at doing the basics. Temperature. We often talk about, we know that the enzymes involved in all of the coagulation processes are temperature dependent. So if you don't have the right temperature, your coagulation starts going screwy. They don't work properly, and it's got a fairly narrow range. The human body is quite good at keeping its temperature within a fairly narrow range, and starts going wrong when it goes outside that. It's only a few degrees, 37 to 42 degrees, 37 to 34 degrees. That's not a lot of change in temperature, but outside those limits, the body doesn't do well because enzymes don't work well. Now, unfortunately, you probably have less control than you think that you do about the injured patient's body temperature. Most of the hypothermia in trauma is because the main source of heat in the body isn't being well perfused. The main source of heat in the body is the liver. When you have lost blood and had injury, you get shut down, the splanchnic circulation shuts down. There's not so much blood going to the liver, and so there's not so much warm blood coming out of the liver, delivering heat to the patient's core. So particularly with a hypovolemic patient, you don't have as much control as you think about that patient's temperature. If they're not perfusing their liver, they're probably going to get cold. But we can do what we can, which is around minimizing exposure. Do you really need to, strip the patient and everyone that comes along takes off whatever warming blanket or blankets you've got on and has another has another look? Minimizing exposure, drying the patient. If the patient's wet, people think about water, evaporative loss. Drying the patient decreases evaporative loss. But remember that blood is just water with bits in it. So if you've got a patient covered in blood, that's also going to be. So drying the patient, whether it's water or blood on the patient, I think is important. Reducing air movement over the patient. We know that air, you can feel a draft, a cold draft. You don't want air moving across the patient. And then having the patient in a warm environment as soon as you can. You can do all of those things. I think it's good to do all of those things. But if you do all of those things and the patient is still hypothermic, don't kick yourself for giving bad care, because actually that's just what happens when someone's not perfusing their liver very well. So part of bleeding is controlling the patient's temperature as far as you can. The next we'll come on to is drugs, and the drug really here is to control bleeding is tranexamic acid, and this is also the sort of second part of my involvement in trauma coagulopathy. The guy on the left there is Ian Roberts, who is a paediatrician, an epidemiologist, and a clinical trialist. Was at the London School of Hygiene Tropical Medicine. He had an interest in trauma through his first big trial, which was the CRASH-1 trial, which was trialing high-dose steroids in patients with significant head injury. He set up with Halima Shakur, who's the next person along in these photographs, who was head of the clinical trials unit and knows, was an expert in delivering large clinical trials and large international clinical trials. So the CRASH-1 study was stopped after it had recruited about 10,000 patients because it definitively proved that high-dose steroids in head injury were harmful, which was a great result because half of neurosurgeons in the world were using steroids, half were not using steroids. So although that trial was negative, it meant that the half that were using steroids stopped using them and it improved patients' outcomes. So even negative trials can improve patient outcomes. But because the trial was stopped halfway through, Ian and Halima then had this worldwide team of hospitals all geared up to deliver research in major trauma patients who were all saying, what's the next trial? What's the next trial? And I had this interest in coagulation, met Ian at one of the TARN conferences, and Ian was saying, well, what should we do next? And I said, well, there are two things that, the problems in trauma are either too much clotting, which gives DIC, for the treatment for which is heparin, or too much breakdown of clot, fibrinolysis, for which the treatment's an antifibrinolytic. And so I said, if you're looking for another drug, it's either heparin or an antifibrinolytic. And we pretty soon decided that actually it might be difficult to convince the trauma community to give heparin to bleeding trauma patients. So we explored the idea of an antifibrinolytic, chose tranexamic acid because it's off-label, it's very cheap, a couple of dollars per patient. It's very well known, very well used, often in oral form for things like period pain, dysfunctional uterine bleeding. And it was also didn't need to be kept in a fridge. It was temperature stable because we were looking at something that could be used worldwide. So it couldn't be something that was expensive or needed a cold chain or any of those sort of things. So tranexamic acid seemed to fit the bill. Also in that picture is Beverly Hunt, who's a hematologist at St Thomas's, head of hematology there. Again, academic hematologist, very influential in creating this study. I think talking about the delivery of the study is a whole new talk, but this was the clinical trials unit at the School of Hygiene, Tropical Medicine in London. Amazingly randomized 20,000, more than 20,000 patients across 40 countries. This is the largest trauma trial that's been done, and that group at London School of Hygiene, Tropical Medicine, fantastic set of skills from those people. Interestingly, trauma clinicians around the world, really interesting, really wanting to take part in this study, really building a sense of community across countries that we're all facing the same problem in the epidemic of trauma care that's going on across the world. So a very inspirational group to be working with. People like the war was going on in Iraq at the time, and we couldn't get the drugs to the hospital, so we got the drugs to one of the air bases, and one of the doctors was driving 200 miles through a war zone to pick the study drugs up to go back. And we were saying to this guy, look, why are you risking? You shouldn't take these risks. And he was saying, well, I'm so isolated and we've got so much trauma. This is the only thing that makes me realize that gives me a community, a professional community of people that I can interact with, and I still feel that I'm being a doctor. Yeah, so really inspirational group. The results were published in The Lancet in 2010. And showed that tranexamic acid significantly decreased death, and in particular death from bleeding after major trauma. So we then went through a phase of getting this introduced. I think in the countries that took part in the study, it very rapidly became normal practice, very rapidly became part of the UK military major trauma protocol. We couldn't do the study in the United States of America because we couldn't afford the insurance for to run a study there. And because we hadn't entered American patients into the trial, the take-up in the USA hasn't been as much as in other countries, although what I think has been increasing take-up in the USA has been the American military have adopted it into their military protocols. Now, we found that TXA prevents deaths, but we also found there was a strong correlation with time from injury, that if it was given less than 1 hour from injury, certainly less than 3 or 4 hours from injury, it had much better, much stronger results. And a bit later on with Mohammed Morsi, we investigated this a little bit to look at why is it that this time-dependent effect of tranexamic acid, that it has much more effect if given early on. So just to recap, we've got in the coagulation system, we've got clot making and clot breaking. So tranexamic acid is influencing the clot breakdown part. It's an antifibrinolytic, so it's stopping clot breakdown. And we saw this diagram before just with normal clot formation and clot breakdown, but here we've got, if things become out of balance and the pro-clotting and anti-clotting processes get out of balance, you get pathological clot formation, pathological thrombosis. If the profibrinolytic and antifibrinolytic processes get out of balance, particularly if the profibrinolytic are not opposed by antifibrinolytic, you get this pathological hyperfibrinolysis, which means that any clot that the body forms just gets broken down and therefore isn't effective at preventing bleeding. If you look at this part, and you look at what are the compounds that are involved, these, again, it's complicated. So I've illustrated this tissue plasminogen activator is profibrinolytic. That is released from cells in the endothelium when they get damaged. So it's the TPA is already there in the cells. Anyone who's perhaps my age will remember TPA as the thrombolysis for heart attacks. So TPA powerfully breaks down clot, and it's there, it's synthesized, it's in vesicles, and as soon as the endothelium is damaged, you've got TPA as part of this balance breaking down clot. And then you've got something called Pi1, which is a naturally occurring antifibrinolytic. We talked about tranexamic acid as a synthetic antifibrinolytic. So Pi1 is a natural equivalent. Now, Pi1 is also activated, or the production of Pi1 is also activated after injury to the endothelium. But the difference is that Pi1 isn't already synthesized in vesicles in the cell. You need to switch on the cell's DNA, and it needs to be manufactured in the cell and then released. So what you get is the TPA being released immediately, but the Pi1 takes time to be made. And so you get this unbalanced, you get this sort of fibrinolysis, unopposed fibrinolysis going on early on. The way that you know that fibrinolysis is going on is measuring something called D-dimer. So, and that is a marker of, it's what's left when the clot breaks down. It's the tiny little bits that go around in the circulation after the clot is broken down. So what we did was measure these various things in trauma patients. And one of our registrars went out in the helicopter and took pre-hospital emergency department 2.5 hours after injury and 5 hours after injury measurements of TPA, Pi1, and D-dimer. And what you see is that in the pre-hospital and ED phases, the TPA levels are really high because they've been released from the vesicles, they're just waiting there to come out. The Pi1 levels are really low because they haven't been synthesized yet. And the D-dimers are really high because there's a lot of clot breakdown going on. And we think that might, if you then look later on, sort of at 3 to 5 hours later, Pi1 levels, the natural antifibrinolytic, Pi1 levels are high. The TPA has sort of done its job and gone away, and the clot breakdown is starting to modify. So what we think might be going on here is that early on, there's no antifibrinolytic because the natural antifibrinolytic takes time to synthesize. So the TXA given very early on opposes and restores the balance, opposing the TPA and other things that are causing clot to form. Later on, after 2, 4, 5 hours, you don't need the extra synthetic antifibrinolytic, the TXA, because you've got plenty of your own antifibrinolytic, and that's where giving more is either not necessary or perhaps even a bit harmful. So this might well be a mechanism by which giving that TXA really early on counts. And I know in the protocols it says within the first 3 hours. Actually, to get most benefit, it needs to be within the first hour. And of course, that means it's a pre-hospital. It really needs to be given pre-hospital because most of the first hour is a pre-hospital phenomenon. So that's why we're trying to push TXA into the pre-hospital phase. I wanted just to spend a couple of minutes talking about what we do to patients to modify their coagulation system, the anticoagulants that a lot of our patients are on, and then they get trauma after we've already been interfering with their coagulation system. Again, if you want to look up the reversal of the anticoagulants, of which there are now quite a number of different ones on the market, here's a great reference and a great nomogram that's come out in the last couple of months. Again, I'll just leave that for the QR code just for a minute if you want to grab that. So let's step into some controversy here. The NICE head injury guidance. I'm sure you are all familiar with 1.5.13, which is has caused a lot of discussion and a lot of anxiety, I think, because this is where you should consider doing a CT head scan on patients that have no other indication for a CT scan after a head injury, but are on an anticoagulant. And of course, doing a CT scan means transporting the patient to hospital, going through the emergency department waiting process, lying flat for a CT scanner, and so forth. It's not just doing a CT scan for the patient. It's quite a big deal, particularly for an elderly patient, to go through that process. So, think of your patient here. You've been called to an 85-year-old female, fall in the care home, bruise on the head. So she bumped her head. No loss of consciousness. She's back to a baseline cognitive state. No other indication that there's anything wrong other than she's on a DOAC for atrial fibrillation. So NICE says that you must now consider a CT scan. So you've got options. You either transport for a CT or you keep her at home. I think before we ask what you would do to put in there, I think there's a first question to ask that is, can a CT scan be done? So if the patient is either too agitated at baseline to lie flat for, you've got to lie flat for 5 minutes to have a flat and still on your back for 5 minutes to have a CT scan. If the patient can't do that, there's no point in transporting them. Just leave them at home, stop the DOAC or the anticoagulant for 4 days, and that is the best that you can do for the patient. The second question after that then is, okay, the patient could lie flat for a CT scan. What's the likely benefit of transport for a CT scan? And let's just have a think about why you're CT scanning, which is to find a bleed. If there's a large bleed, this patient isn't going to get neurosurgery at 85. She's not going to be able to recover and rehabilitate from the procedure, so she'll be having palliative care. She's unlikely to have a large bleed if she's back to baseline. If there's a small bleed or a contusion or something like that on the CT scan, she definitely doesn't need to go to a neurosurgeon. We'd admit her to hospital, stop the DOAC for 4 days, observe in hospital for 24 or 48 hours. And then if the patient deteriorates, she's still not going to get neurosurgery, so we probably move on to palliative care. In the last year or so, we've also got to consider reversal agents. There are now antidotes for the DOACs. They're really expensive, about £3,000 per patient to use them. And the role in head injury is not really established yet, and how much better reversal is than just stopping the drug. So you've got to think that actually taking someone to hospital and putting them through that is adverse for the patient. On the other hand, finding a bleed, stopping the DOAC and stopping a rebleed is a benefit for the patient. So you've got to then sort of weigh up risks and benefits. And here's a question for you. How many patients would you transport to hospital to go through the CT scanning, et cetera, to prevent one patient deteriorating from their head injury? Tell you what, why don't you try putting a number in the chat? What do you reckon? If you're not going to put it in the chat because that's got your name attached, write it down on a bit of paper in front of you. I like that specific 21. That's a really good. That's really good. I think that a deterioration is a fairly bad thing. I think I'd transport quite a few people. I'm probably nearer the 50, 63. We got a 200 and a 500. Yeah. So again, it sort of depends on, transport. How many patients are you going to transport to find that one deterioration? So remember that number. And what I'd like to do is just to sort of work through some of the statistics around it. So what we know is if you scan patients age greater than 65 and they're on a DOAC, and their only indication for scan is the fact that they're on a DOAC or other anticoagulant, you could put warfarin instead of DOAC, really. About 2% of the patients are going to have a bleed on the CT, about 1 in 50. Of the patients with a bleed, about 16% are going to deteriorate. So 16% of 2% is 0.32%. That is 1 in 312 are going to likely to deteriorate. And I reckon about half the deteriorations will be prevented by a reversal agent. So in order to prevent, or by stopping the DOAC, about half the deteriorations will be. So in order to stop one deterioration, you'd have to transport 625 patients. So your transport, scan and reverse strategy to prevent one deterioration, you need to transport and scan 625, admit and stop the DOAC or reverse 12.5 for 2 patients who needed the reversal, of which 1 will be prevented from deteriorating. And then you'd also be giving an unnecessary drug with side effects to 10 patients. So 625 is the magic number. And I noticed that nobody in the chat put in a number as big as 625. So in all of your risk estimations, even the highest risk estimation at 500, what you're saying is that this patient shouldn't be transported for a CT scan and reversal if necessary. Now, it's complicated, and I think someone's put in the chat that it also depends on journey time, other factors, patient choice. Yes, there are a whole load of other things that come into it, which is, I think, why NICE says consider. But if you look at those numbers, what I think we're saying is that most patients where the anticoagulant is the only reason for doing a CT scan probably shouldn't be transported to hospital. So yeah, risk best benefit. There's an alternative strategy, which is stay in the home, stop the DOAC for 4 days. You are doing something positive, because actually if the CT scan was positive, that's all we'd do in the hospital would be to stop the DOAC for 4 days and watch the patient to see whether they deteriorated or not. And that can be done just as well in a care home as it can in the hospital. Now they're on the anticoagulant because of atrial fibrillation. 4 days off, missing 4 doses isn't going to give you clot in your fibrillating atrium, which goes and gives you a stroke. It's really unlikely to do that for just 4 or 5 days. And I don't know, to me, that seems like a better strategy, and a better strategy for the patients to have their anticoagulant stopped at home or in the care home. Now, I think if they're on their own at home and they're not able to, perhaps be observed, that might change what you're considering. And I think that's why NICE puts that word consider, because it's quite difficult to write a hard and fast rule for how to do this. And each case is a little bit different. The circumstances are a little bit different. But I think in general, we're probably CT scanning way too many, particularly older people, simply because they've had a bump on the head on anticoagulants. I look forward to having some discussion about that, because there's been quite a bit of discussion around it. So how are we doing on time? We're doing okay. In summary, I've talked a little bit about this coagulopathy that's been recognised over the last 25 years or so. that is an intrinsic part of major trauma caused by the disruption to the endothelium. We talked a bit about blood clotting after trauma, seeing it's a series of really complex molecular pathways and enzymes that give a balance between pro-thrombotic, anti-thrombotic, anti-fibrinolytic, pro-antifibrinolytic, and anti-antifibrinolytic processes. We've looked at ways of reducing blood loss and particularly emphasized just good patient handling and good patient care. And then we talked a bit about the impact of anticoagulant drugs and how your decision-making might be impacted by anticoagulant drugs, particularly in regard to patients that have got head injuries. I'd be really happy to take questions and have any discussion. I think Anna's going to come on and moderate the questions.
I am indeed.
You say her name, and she appears.
That's what happens at at conferences as well. People say my name, and I'm just suddenly there, ready to help. So, thank you very much, Tim, for that incredibly informative, educational, and hopefully slightly debatable talk that you've just given there. Before we move on to the Q&A, I just want to draw you're all going to forget this over Christmas, let's be honest, but just in case, and as we are back in January, I just want to draw people's attention to our first webinar of 2025. That's really weird to say. We are going to be looking at managing polytrauma patients in ICU by Dr. Krishna Nathan. They did tell me I'll say this the other day. Do scan the QR code that's on your screen now. It'll take you through to be able to register for that webinar for free. So we are going to be looking at polytrauma, which is always a highly interesting talk. I love learning about polytrauma, probably because I suffer from it myself so often. So many broken bones. Anyway, the Q&A. This is the section that we all enjoy asking questions, and Tim will answer them. I've seen a couple pop up so far, which is great to see. And of course, if you are not a member of Trauma Care, this is your opportunity to scan the QR code that's on your screen now. This will take you through to the type form, which will allow you to pay £1.99 to purchase your certificate. If you are a member of Trauma Care, or if you plan on signing up within the next 24 hours, don't scan the QR code. We will be sending your certificate free of charge tomorrow. So to begin with, what came here first? Okay, Adam Hoskins asked, what are your thoughts around the lack of movement you mentioned around log rolling, etc., versus the latest paper released by Tim Nutbeam and the Faculty of Pre-Hospital Care around patient self-extrication and changes leading to more movement, not less? I think that's in reference to the impact paper that's just come out.
Yeah. So I think that patients being able to move themselves is a really good indicator that actually they're not going to do themselves too much damage. And I think that's what Tim was thinking about when he did that study. It's something that when we were working together, we were definitely, saying to patients, can you get yourself out? If you can get yourself out, please do. And that was rather against the sort of philosophy at the time as well. But any of you that have broken bones know that, if you've broken something, you really, really don't want to move it. And so if the patient does want to move it, is able to self-extricate, I think that's fine, because they're not in the group that has got this severe bleeding. We're thinking about, smashed pelvis, multiple rib fractures, that as you move, the ends of the bones grate together and all the clot that's been trying to form on the ends of the bones gets knocked off and there's another set of bleeding. So I think that's a different group of patients. The self-extrication patients are a different group.
Perfect. Very, very well answered. So Lee, I can't pronounce your last name, I do apologise, has asked, good evening. Is there a slight variant in the components and their ratios that make up venous clots versus arterial clots of clinical significance in the management of, you always do this to me, guys, hemorrhagic trauma? And do the different characteristics of these clots make TXA more effective for venous bleeds or arterial bleeds?
I think I can answer that very quickly, that yes, really interesting questions. Nobody knows.
Brilliant.
So I think there is something about the pressure in the vessel having an effect as well. People talking about popping the clot. Certainly in surgical conditions like leaking abdominal aortic aneurysm, we know that keeping the pressure down in the vessel is really important until the surgeons can get in there and do something. So, is there a difference between venous and arterial? I don't know in the clot itself, but certainly in the environment around the clot and the pressure around the clot, there would be a difference. Is TXA more effective in one than the other? There is absolutely no evidence, but it's a really interesting and it's a good question to ask.
Perfect, thank you. An anonymous attendee has asked, how long is TXA's mechanism of action such that it won't be deleterious by being in excess when PIA comes into action too?
Yeah, so again, interesting. The initial sort of bolus followed by an infusion, we were thinking that we want to get the TXA out of the system before the acute phase response comes in, which really comes in at about 24 hours. So we did the bolus, 8 hours infusion, TXA lasts about 8 hours, and then an 8-hour washout, and we thought that would be about right. There's a lot of there's some evidence now that actually the infusion perhaps isn't that important. And it's the bolus dose. So instead of a gram bolus and a gram infusion, there are a number of centers, and there's a little bit of evidence from 2 American studies that a 2-gram initial bolus is absolutely fine. So that most of its effect over the first 4 hours, it will tail off down to about 8 hours. So I suspect that in 10 years' time, we're not going to be doing the infusion. We're just going to be giving a probably slightly larger dose of tranexamic acid earlier on, and we're probably going to be giving it by the intramuscular route rather than the intravenous route in a much more concentrated form, perhaps using something like an EpiPen, all being worked on at the moment.
Yes, and that's actually really interesting. We, I don't know if people know this, but we actually did a webinar back in August by Dr. Jake Gillis-Harris, who was actually speaking about this exact study and talking about the intravenous bolus and sort of where it's heading, and referenced this study quite a lot. So if people do want to learn more about it, that is available on our YouTube channel as well. So you can learn more about Tim's points there by looking at that webinar. Who was next? I'm trying to do these in order, guys, and make sure that everyone gets answered. So another anonymous attendee has asked, we've got a lot of people named anonymous tonight. In patients with traumatic liver injury, what degree of temperature loss can we expect? And in trauma in general, what would the expected temperature loss be in the magnitude of?
So I'm going to answer a lot of these questions by saying it's complicated and I don't really know. So the temperature loss isn't actually due to the liver injury. It's due to the blood loss from other injuries that stops blood going into the liver, which is like the furnace producing the producing the heat in the body. So if there's not blood going into the liver, then the heat isn't circulating, and the patient gets cold. So so liver injury, I'm not sure makes that much difference to that. The second part was how much temperature drop you could expect with different
trauma in general
injury. There's not a good relationship between injury severity and temperature loss.
Fair enough, brilliant.
And I can make up all sorts of explanations for that, but I'd be making them up.
And we don't want to do that.
Individual variation and so forth. So yeah, it's complicated.
Brilliant. Thank you very much. So we have got about 13 questions to get through, everyone. So I'm going to try and see which ones are slightly similar. And then if yours isn't asked, it's because it's similar to another question. So Adam's asked, with regards to minimizing how long the patient is bleeding, is it better to run to the emergency department 20 minutes away or the trauma unit 40 minutes away?
Okay, so I'll try and answer quickly. To put this into the UK language, it's either a trauma unit, that is the emergency department nearby, or a major trauma centre, which is the more distant one, 40 minutes away. The UK protocol, which I help write, is that if you're within 45 minutes of the major trauma centre, you should go there. A lot of trauma units, they just don't have the volume of experience of stopping bleeding in these patients to actually do that. So you're better to spend those extra few minutes in the pre-hospital phase to get the patient rapidly through to the right surgeon to be able to do the job.
Perfect. Patients, I do think. Okay, really interesting discussion, a lot based on transport decisions. Do you think pre-hospital providers are supported in making these decisions?
Uh, no.
Yes.
Now, there are some systems that support them. In Leicestershire, we've got a system where we say any patient that's being picked up from a care home for a care facility, they have a phone call, a hotline number to a geriatrician before the patient could be transported to A&E, unless it's unless they're being resuscitated. So there are places where there are these systems in place where you can actually discuss a case and then come to a decision around what's the best thing to do. But in a lot of places, I think you're very much on your own. These are complicated decisions, and I don't think negatively of anyone who brings the patient to hospital, so that those decisions and those talks with the family and talks with the patient can go on. That's sometimes hard stuff to do in the pre-hospital phase.
Okay, brilliant. Thank you. Just trying to find the most. Okay, so this is quite could be a slightly out there question, but a PT with a paroxysmal AF is bunged on a DOEC for 1% per annum stroke risk. They get older and frail and get into their falls window. As trauma specialist, should we be advocating taking them off it, or at least a review of risk benefit?
Absolutely, yes. So it's something that the geriatricians are doing the whole time. Is patient comes in after falls, they look at the drugs and they say, look, they've had 3 falls in the last year. They want to go home. They're going to continue falling. They really don't need to be on the risk of being on an anticoagulant. It changes that risk benefit balance. So yes, for a lot of drugs, not just the anticoagulants, as risk benefit balance changes, you should have a review.
Perfect. So there's been a lot of questions coming about TXA, so I'm going to lump them all into one so you can kind of answer them. Should we rebolus TXA within the first hour in cases of ongoing massive blood loss and transfusion? And also, why did NICE recommend a 2G dose of TXA for head injury? Is one lumped together question.
Yeah. So for the first one, tranexamic acid is actually it doesn't turn off bleeding like that. It changes the balances. So if you've got a patient that has got big bleeding, I don't think TXA is going to have that much effect. That patient needs to get to a surgeon to sew up the holes in big vessels. So I hope that answers the first bit. The second bit is, why did NICE? So now we have 2 recommendations for TXA dosing, one for head injury and one for multiple trauma, that are different from the same organisation. So what do you then do if you've got a patient with major injury and a head injury? I think it's just confusing. It's because the head injury literature, a 2-gram dose happened to be used. And in the major trauma literature, we happen to choose the 1 gram followed by a 1 gram infusion. The only rationale for that, that there was no evidence that 1 gram followed by infusion was any better. We decided that on the back of an envelope, sitting in a room down in the School of Hygiene Tropical Medicine, was going to be what we used as a regime, because we thought that actually it would be deliverable and easy to deliver in the pre-hospital phase and then in the A&E phase. We could have gone for a 2-gram bolus and everything would have been the same. So I don't think there's evidence that one is that much better than the other. And I think in future, probably 2 grams for everybody as an early intramuscular dose is probably going to be where we're going.
Perfect. So Okay, so I am going to say, please don't send in any more questions, guys. I'm going to try and run through these as quickly as possible. We've got 6 questions to go through. So, what is the physiological intrinsic reason for TPA being released automatically during trauma? Isn't this deleterious?
So interesting. Difficult to give a short answer to. Let me try. So most of our body processes are created by evolution, and our bodies are evolved. Evolution is, if you get an injury, if you've got good coagulation and stop the bleeding, your genes are likely to be passed on, therefore these things evolved. I don't think our bodies ever evolved to respond appropriately to major trauma, because if you're a caveman and you got major trauma from a saber-toothed tiger, you didn't pass your genes on. So I think that our bodies are perfectly adapted to respond to, a broken leg, a laceration, that sort of thing, where you want a whole bunch of TPA to come out to stop the bleeding, and then in the fullness of time, the antifibrinolytics will just mop up so that you mop up your arm. I don't think our bodies are adapted to having this huge volume of endothelial injury, and so I think we've got some body responses that have not evolved to be appropriate for major injury. Major injury is surviving major injury has only happened in modern times. We're not evolved to cope with it. That
Brilliant.
wasn't
Thank you
the
very
clearest
much.
explanation, but I think that's where we're going.
Yes, perfect. Who would you expect to discontinue DOACs in the pre-hospital environment prior to leaving at home?
That's interesting, isn't it? So I think it is, absolutely within the skill set of a paramedic to do that. The difficulty is, are you going to be supported in that decision? Firstly, by the the medical system within your own organisation, and then external scrutiny. Most difficult decisions in medicine are better shared. I share a lot of my difficult decisions with colleagues in the emergency department. So, I think the system of having that as phone a friend, which could either be an advanced practitioner, the geriatrician system we have in Leicester, or a GP. But I think it is. I think it's only a big deal decision because we made it a big deal decision. I think stopping a DOAC for 4 days is, you do things to patients that are much more dangerous than stopping a DOAC for 4 days already. So there's no reason why this shouldn't be in a paramedic's remit.
Perfect. Lawrence has asked, does renal function and severe CKD impact the dose of initial treatment with TXA?
No, because you need to give it really as soon as you possibly can. And the first dose just goes around the body and isn't renally excreted in the time that it's working. You don't know what the patient's renal function is when you're giving it. So no is the answer.
Perfect. Mike McIver, thank you very much, Mike. You always ask a good question. Is there much potential for other antithrombolytic agents to be trialed in comparison to TXA in the future? I do know that one as well, because something that I suffer with.
I mean, we chose TXA over a protein because TXA is a bit more stable for being used in hot countries. I'm really glad we did, because about 6 months after the Crash 2 study started, a protein had its license withdrawn. If we'd have chosen a protein, we'd have just folded and we'd have never been probably having this webinar. There isn't a lot of other. There is mine's gone blank on the third antifibrinolytic agent, aminocaproic acid. I think it's less easy to use. People are less familiar with it, and I think TXA is such a familiar agent now that it's probably not going to have any competitors. If you were going to do the trial of tranexamic acid against another, remember, tranexamic acid against nothing took 20,000 patients to show the difference. you're going to do the trial, you're going to need many times that number. It's just not feasible. So no, I think with tranexamic acid is probably not going to have a competitor.
Fair enough. Craig Ellis has asked, is there any patient? Can tell it's getting to the end of the year, can't you? Okay, I think it's just a bit of so is there any patient harm to administer more than 1 gram of TXA in the 3-hour window, or like you mentioned, 1 hour?
No, the 1 gram initial bolus dose, we're wanting this trial to be done across the world, particularly in countries where people are smaller, perhaps, than those in Western Europe. So we were thinking of, a woman in Asia. So we chose the 1 gram dose to sort of be appropriate. It's just about enough for someone of my sort of size, and it's a good dose, and probably at the top of the dosage range for a small female. So that's why so 2 grams, I think, it's got a very, very wide window. 2 grams, I don't think there's much evidence of patient harm from that. The patient harm from tranexamic acid is when it's rapidly given before neurosurgery to patients that are having surgery for epilepsy. And they had a few patients that fitted when being given the tranexamic acid. So this link between tranexamic acid, large dose being given rapidly, and fitting, but that was only in patients that were having epilepsy surgery, and they're a pretty special subgroup of patients.
Fair enough. And our last question is from an anonymous attendee again. Of all the pre-hospital interventions ambulance crews can perform to manage these type of patients, is there any one that is shown to be the most effective for reducing chances of coagulopathies if all else were equal? I need to put my tongue back in my mouth tonight.
Yeah, I don't know that anyone's really done comparative, or it'd be quite difficult to do comparative studies of which bit is, the most effective. Now, there's quite a lot of places in medicine where we do a bundle of care, and we know the bundle gives better outcomes. But if you look at each bit of the bundle, it's difficult to show that bit improves the outcome. And I think here you're looking at a bundle of care. What we need to be doing is looking across all of the different factors, the physical, the environmental, the drugs, and getting it right in all of those aspects. If you do all of that as a package, that's what gives better care, better outcomes.
Perfect. Thank you so much, Tim, for taking the time to answer all, and thank you everyone as well for throwing so many questions at me. Really set my knowledge on fire there, trying to say all the words. But thank you so much. I think that's the most questions we've had in a long time, which just shows the caliber of your presentation, Tim, and how good it was. So thank you very much, everybody, for joining us this evening. Before we leave, I do have to give the shout outs to our wonderful friends and sponsors over at QualSafe, who are brilliant first aid educators. They've got loads of brilliant things that are going on. They teach FREC4, they teach all sorts. If you go over to qualsafe.org, ignore the awards, go over to qualsafe.org, you can find out more about all the different things they have available. And of course, a huge thank you to Nigel and Toby who are putting together our first aid programme for the 27th annual conference as well. And our good friends and long-standing friends, probably our longest-standing friends, Galen. I can't speak too much about them due to the fact that I'm not qualified to, and I'm not allowed to by their administrator. But if you go over to galen-pharma.com, you can find out more about all the things that they do create, produce, and have available. You never know, something you use in the future might be in there. So that is all from us this evening. Thank you, everybody, for joining us this year, tonight, across the board. Really appreciate it. Tim, thank you for taking the time to join us this evening. I'm sure we will be seeing you again in the future. To everyone, no matter where in the world, whether you celebrate, if you don't, have a happy holidays, a brilliant new year, and see you all, hopefully, on the 9th of January. I'm going to stop sharing my screen now. Have a wonderful Christmas, everybody, and thank you very much. Goodbye, all.
Thank you.